Hi, welcome to the Dr. MEK Anesthesiology podcast series.
Hello.
In this series, we provide insights into critical topics in anesthesiology.
Yes.
With the goal of enhancing your understanding and practice as fellow anesthesiologists.
For sure.
Before we begin, please remember this podcast is for informational purposes only and does not constitute medical advice.
Yes.
For personalized medical guidance, please consult a qualified healthcare professional.
Absolutely.
Today, we'll be examining
Fair.
Postreperfusion Syndrome,
Yes.
or PRS,
Yes.
a serious complication that can arise during liver transplantation.
For sure.
Our primary source is the insightful article, Postreperfusion Syndrome, from Open Anesthesia, last updated on January 13th, 2025.
Okay.
You are listening to the Dr. MEK series.
All right.
Now, let's discuss why understanding PRS is so crucial for anesthesiologists.
Well, PRS presents a considerable challenge in liver transplantation.
Okay.
It significantly contributes to morbidity and mortality. Recognizing and managing this syndrome effectively is paramount to ensuring the best possible outcomes for our patients undergoing this complex procedure.
Absolutely. The Open Anesthesia article provides a specific definition of PRS that helps us understand the precise diagnostic criteria.
It defines PRS as a decrease in mean arterial pressure, or MEK, of more than 30%.
Okay.
Below the anapatic phase baseline.
Okay.
This decrease must occur within 5 minutes of the graft being reperfused and last for at least 1 minute.
Okay.
It emphasizes the hemodynamic instability that characterizes this syndrome.
And it goes on to categorize the severity of PRS.
Yes. It differentiates between mild and severe PRS.
Okay.
Mild PRS involves a MAP reduction of less than 30%, lasting under 5 minutes.
Okay.
It's often accompanied by bradycardia,
So?
requiring calcium or epinephrine boluses for pressure support without needing a continuous vasopressor infusion.
While severe PRS presents a more serious scenario.
Precisely severe PRS involves a sustained decrease in MAT exceeding 30%.
Right.
It can be associated with asystole or other cardiac dysrhythmias requiring prolonged vasopressor infusion, potentially with fibrinolysis.
Wow.
We're talking about a situation that demands immediate and decisive action.
The article also mentions that the reported incidence of PRS varies quite a bit, doesn't it?
It does. The reported incidence ranges widely between 6 and 77% of patients undergoing liver transplantation.
That's a big range.
This variability is largely attributed to the lack of a consistent definition of PRS across studies.
You're listening to the Dr. MEK series.
Okay.
So understanding this lack of a standardized definition, how can anesthesiologists ensure they're adequately prepared to recognize and manage PRS?
It emphasizes the importance of being aware of the various presentations of PRS and carefully monitoring hemodynamic parameters in the critical period following graft reperfusion. Early recognition is key to effective management.
Now let's talk about the risk factors associated with PRS. The article categorizes these factors into donor graft, recipient, and procedural factors.
That's correct. Multiple studies have identified these various risk factors.
Okay.
Being aware of these risk factors helps us assess the likelihood of PRS in individual patients and tailor our anesthetic management accordingly.
Let's break down each of these categories, starting with donor graft factors.
Okay.
What are the key considerations there?
When considering the donor and the graft, advanced donor age, prolonged cold ischemia time, the presence of macrovesicular steatosis, and size mismatch, where a larger graft is used for a smaller recipient, all increase the risk of PRS.
So the condition of the donor and the characteristics of the graft play a significant role in the development of PRS.
Absolutely. It highlights the importance of careful donor selection and organ preservation techniques. These factors are often beyond our control as anesthesiologists, but understanding their impact helps us anticipate potential challenges during the transplant procedure.
What about recipient-related factors?
Okay.
What are the key considerations there?
Moving on to recipient-related factors, advanced age, a higher MELD score, elevated creatinine levels, hyperkalemia, hypocalcemia, anemia, pre-existing left ventricular dysfunction, and fulminant hepatic failure are all associated with an increased risk of PRS.
So a patient's overall health status before the transplant significantly impacts their susceptibility to PRS.
Precisely. This underscores the importance of a thorough preoperative assessment.
Yes.
To identify potential risk factors and optimize the patient's condition before surgery.
Okay.
This allows us to better anticipate and manage potential complications like PRS.
And finally, procedural factors also contribute to the risk of PRS.
Indeed, prolonged warm ischemia time,
right.
the absence of portal vein flushing prior to reanastomosis,
okay.
and the use of the classical inferior vena cava interposition technique without piggyback anastomosis have all been linked to a higher incidence of PRS.
It seems that meticulous surgical technique is crucial for minimizing the risk of PRS.
Absolutely. Close collaboration with the surgical team is vital.
Yes.
Communication and coordination throughout the procedure can help minimize warm ischemia time.
Right.
And ensure meticulous surgical technique, reducing the risk of PRS and other complications.
Now that we have a good understanding of the risk factors,
yeah.
let's delve into the pathophysiology of PRS.
Okay.
It's a multifaceted process, isn't it?
It is. The liver typically holds a significant volume of blood, between 250 and 500 milliliter.
Okay.
When the graft is reperfused, this blood volume needs to be replenished,
right,
leading to a reduction in cardiac preload.
Okay.
Additionally, the blood passing through the cold graft gets chilled,
right,
and some of the preservation fluid used to store the graft can enter the systemic circulation.
Oh.
These factors combined can cause myocardial depression due to the sudden temperature change,
okay,
and associated electrolyte disturbances.
That makes sense. What other factors contribute to the development of PRS?
Another critical aspect is the reperfusion of the ischemic bowel,
okay,
which occurs due to venous congestion and surgical handling during the hepatectomy phase.
Yeah.
This reperfusion leads to the release of acidic fluids,
okay,
cytokines, and endotoxins into the systemic circulation.
And how do these substances impact the body?
These substances further depress myocardial function,
right,
and trigger an inflammatory cascade,
right,
resulting in persistent systemic vasodilation.
So they make things worse.
Essentially, they exacerbate the already compromised cardiovascular state.
So we have a combination of reduced preload myocardial depression and systemic vasodilation, all contributing to the hypotension seen in PRS.
Exactly. And there's more.
Okay.
The reperfusion of the ischemic graft itself also induces cellular edema and apoptosis, due to alterations in the function of the sodium-potassium pump.
That must further compromise the function of the newly transplanted liver.
It does. Additionally, the reperfusion process leads to the release of reactive oxygen species, which activate Kupffer cells.
Okay.
These cells are resident macrophages in the liver,
right,
and their activation triggers the release of inflammatory cytokines, like tumor necrosis factor alpha and interleukins 1, 6, and 8.
So we have a complex interplay of factors all contributing to a systemic inflammatory response.
That's right. And it's important to note that most of the liver graft injury that occurs during transplantation is attributed to this inflammatory response.
Clearly understanding the pathophysiology of PRS is key to effective management.
Absolutely. This understanding helps us anticipate the physiological changes that occur during reperfusion, and implement strategies to mitigate the negative consequences.
We've covered a lot of ground in this first part of our discussion on Postreperfusion Syndrome.
Yes.
It's clear that this is a complex and multifaceted issue that requires a deep understanding of its pathophysiology and risk factors.
Indeed. Recognizing these factors is crucial for anesthesiologists involved in liver transplantation to optimize patient outcomes.
We will continue our exploration of Postreperfusion Syndrome in Part 2, where we will delve into management strategies and the impact of PRS on patient outcomes.
All right.
Stay tuned.
See you then. Welcome back to the Dr. MEK Anesthesiology podcast series. We're continuing our discussion of Postreperfusion Syndrome in liver transplantation.
Yes.
In this section, let's focus on management strategies for PRS.
All right.
The Open Anesthesia article emphasizes that the primary goal is to reverse the pathological changes we discussed in Part 1.
Right. So how do we do that?
That's correct. The management of PRS involves a multi-pronged approach aimed at restoring hemodynamic stability, correcting electrolyte imbalances, and mitigating the inflammatory response.
So what are the core components of this approach?
First, fluid resuscitation is crucial to counteract the decrease in preload that occurs during graft reperfusion.
Right.
This helps maintain adequate cardiac output and blood pressure.
So we're aiming for hemodynamic stability.
Precisely.
Yeah.
And in addition to fluid resuscitation, heart rate stabilization is equally important. Both severe bradycardia and tachycardia need to be addressed promptly. Any arrhythmias should be corrected to restore normal sinus rhythm.
So how do we approach heart rate management in the context of PRS?
Management depends on the specific arrhythmia and the overall clinical picture.
Right.
Bradycardia may respond to anticholinergic medications like atropine,
Okay.
while tachycardia might require beta blockers or calcium channel blockers.
Okay.
In cases of hemodynamically significant arrhythmias, prompt electrical cardioversion may be necessary.
So it's a dynamic process that requires ongoing assessment and adjustments.
Absolutely.
Yeah.
Now, in addition to fluid and heart rate management, vasopressors are frequently used to combat the vasodilatory effects of the inflammatory cytokines released during reperfusion.
Which vasopressors are commonly used in this setting?
The choice of vasopressor depends on the individual patient's hemodynamic status and comorbidities.
Right.
Norepinephrine is often the first-line agent due to its combined alpha and beta adrenergic effects.
Okay.
It helps increase both blood pressure and cardiac output.
And what about myocardial depression?
Okay.
How do we address that?
In cases of significant myocardial depression, inotropes are often necessary to support myocardial contractility.
Can you elaborate on the role of inotropes in PRS management?
Inotropes like dobutamine or milrinone increase the force of heart muscle contraction, thereby improving cardiac output.
Okay.
They're particularly useful when myocardial depression is contributing to hypotension and inadequate organ perfusion.
It seems like a delicate balancing act managing fluids, vasopressors, and inotropes.
It can be. The key is to carefully titrate these medications based on the patient's hemodynamic response.
Okay.
Continuously monitoring vital signs and adjusting therapy as needed.
Electrolyte and acid-base correction are also essential components of PRS management, aren't they?
They are. We need to address the metabolic derangements that occur during liver transplantation and the reperfusion process.
What specific electrolyte and acid-base derangements are we looking at?
Typically, we focus on calcium and magnesium supplementation, as both are reduced by citrate chelation during blood product transfusion. Hypocalcemia can exacerbate myocardial depression and increase the risk of arrhythmias, while hypomagnesemia can contribute to both cardiac and neurological complications.
And how do we manage acid-base disturbances?
We often administer bicarbonate to address metabolic acidosis, which can result from poor tissue perfusion and lactic acid buildup. Correcting acidosis helps improve cardiac function and optimize cellular metabolism.
So it's a holistic approach addressing multiple physiological derangements.
Exactly. We aim to stabilize the patient's hemodynamics, correct electrolyte imbalances, and optimize acid-base status to support the newly transplanted liver and promote overall recovery.
Beyond these standard therapies, the Open Anesthesia article also mentions some investigative therapies that have shown promise in treating refractory cases of PRS.
That's right. These therapies target specific aspects of the pathophysiology of PRS.
Can you give us some examples of these investigative therapies?
Some of these include methylene blue, which scavenges reactive oxygen species, hydroxycobalamin, which scavenges nitric oxide, and acetylcysteine, which acts as an antioxidant by restoring glutathione stores. These agents aim to reduce the oxidative stress and inflammation associated with reperfusion.
Are there any other experimental therapies being explored?
Yes, protease inhibitors to reduce fibrinolysis and magnesium sulfate to suppress inflammatory cytokine production are also being investigated.
It sounds like the research in this area is ongoing.
It is, and new treatment modalities are constantly being explored. As our understanding of the complex mechanisms underlying PRS evolves, we can expect to see further advancements in its management.
You are listening to the Dr. MEK series. Now that we've covered the core management strategies for PRS, let's shift our focus to the impact of this syndrome on patient outcomes. The Open Anesthesia article highlights several key points in this regard.
It does. A severe PRS has been associated with a number of negative outcomes, including increased blood product transfusions, higher rates of postoperative renal dysfunction, extended ventilatory support, longer ICU and hospital stays, and a greater risk of needing retransplantation.
That's a significant list of potential complications. Let's break down each of these outcomes, starting with blood product transfusions.
Patients with severe PRS have been shown to require more blood product transfusions, including red blood cells, fresh frozen plasma, and cryoprecipitate compared to those with mild or no PRS. This is due to the coagulopathy and hemodynamic instability associated with severe PRS.
So the severity of PRS directly correlates with the need for blood products.
Yes, and this increased need for transfusions has its own set of implications, including the risk of transfusion-related complications such as allergic reactions, transfusion-associated circulatory overload, and infection.
What about postoperative renal dysfunction? How does PRS impact kidney function?
Severe PRS can lead to acute kidney injury. Due to the combination of hypotension, reduced renal blood flow, and the nephrotoxic effects of some medications used during transplantation.
And how does PRS affect respiratory function?
Patients with severe PRS often require prolonged mechanical ventilation due to respiratory complications such as pulmonary edema and acute respiratory distress syndrome. These complications can arise from fluid overload, inflammation, and impaired lung function.
So PRS can have a cascading effect leading to multiple organ dysfunction.
It can. The systemic inflammatory response triggered by reperfusion can affect various organ systems, including the lungs, kidneys, and heart.
The article also mentions an increased risk of retransplantation in patients with severe PRS.
That's correct. Severe PRS can contribute to graft dysfunction and failure, increasing the likelihood of needing a repeat transplantation. This is a major complication with significant implications for the patient's health and well-being.
So while we strive to prevent and manage PRS, it's important to acknowledge that it can have long-term consequences.
Absolutely. The goal is to minimize the incidence and severity of PRS. But we must also be prepared to manage its potential complications.
The Open Anesthesia article also addresses the impact of PRS on survival.
Yes, it does. Determining the precise impact of PRS on patient and graft survival is challenging due to the many confounding variables related to the recipient, the graft itself, and procedural factors. However, the complications associated with severe PRS clearly underscore the importance of early recognition and aggressive management.
So while the direct impact on survival is difficult to isolate, it's clear that PRS can significantly affect patient recovery and long-term outcomes.
Precisely, and that's why a thorough understanding of PRS, its risk factors, its pathophysiology, and its management is essential for all anesthesiologists involved in liver transplantation.
We've covered a lot of ground in this second part of our discussion on Postreperfusion Syndrome. We've delved into the intricacies of management strategies. And explored the potential impact of PRS on various patient outcomes.
Indeed. We've highlighted the critical role anesthesiologists play in recognizing and managing this complex syndrome.
In the final part of our discussion, we'll wrap up by summarizing key takeaways. And offering some final thoughts on this important topic.
All right.
Stay tuned.
We'll see you then.
Welcome back to the Dr. MEK Anesthesiology podcast series. In this final part of our discussion on Postreperfusion Syndrome. Let's highlight some key takeaways for anesthesiologists. And consider their implications for our practice.
That's a great way to wrap up this complex topic. We've covered a lot of ground from the definition and pathophysiology of PRS to its management and impact on patient outcomes.
As we've discussed, PRS is a serious complication of liver transplantation.
Absolutely.
That can significantly impact patient outcomes.
For sure. And as anesthesiologists, we play a crucial role in recognizing the risk factors for PRS, implementing preventative measures, and promptly addressing any hemodynamic or metabolic derangements that occur during the perioperative period.
One key takeaway is the importance of a thorough preoperative assessment.
That's right. Identifying patients at higher risk for PRS, such as those with advanced stage high MLD scores or pre-existing comorbidities, allows us to tailor our anesthetic plan and optimize their condition before surgery.
Another crucial aspect is close collaboration with the surgical team.
Absolutely. Communicating effectively with our surgical colleagues helps ensure meticulous surgical technique and minimizes warm ischemia time, both of which are critical for reducing the risk of PRS.
Intraoperatively, vigilance is key.
We need to closely monitor hemodynamic parameters, electrolyte levels, and acid-base balance throughout the transplant procedure. Early recognition of any signs of PRS allows for prompt intervention and hopefully mitigates the severity of the syndrome.
And as we've discussed, management of PRS is multifaceted.
Indeed. It involves fluid resuscitation, heart rate stabilization, vasopressor support, inotropic therapy if needed, and correction of electrolyte and acid-based disturbances.
Beyond these standard therapies, we also discuss some investigative therapies that are being explored for refractory cases of PRS.
These include agents like methylene blue, hydroxycobalamin, and acetylcysteine, which target the oxidative stress and inflammation associated with reperfusion. It's an area of ongoing research, and we can expect to see further advancements in the management of PRS in the future.
Finally, it's essential to recognize the potential long-term consequences of severe PRS.
Patients with severe PRS are at increased risk for complications such as renal dysfunction, prolonged ventilation, longer hospital stays, and even retransplantation. These potential consequences underscore the importance of early recognition and aggressive management.
To our listeners, we encourage you to delve deeper into the Open Anesthesia article we've referenced throughout this episode. It provides a comprehensive overview of Postreperfusion Syndrome, its pathophysiology management, and implications for patient care.
Staying informed about evolving challenges in anesthesiology is key to providing the best possible care. We hope this discussion has enhanced your understanding of Postreperfusion Syndrome and its management in the context of liver transplantation.
Thank you for joining us for this deep dive into Postreperfusion Syndrome. We appreciate you being a part of this learning journey.
Don't forget to subscribe to the Dr. MEK Anesthesiology podcast series and hit the notification bell to stay updated on our latest episodes.